So week 4, we're doing chapters 37, 38, 39. I want you to pay good attention, and you really need to go to your book and look at chapter 39. 39 is big, has so much information in there. Okay, and I know that I've seen the blueprint of what exam 2 is, and there's things on there that you need to read. Those little boxes are always the important places. You know that. Those are where questions will be coming from. So just to give you your heads up. So let's go ahead. Let's get our cahoots going. I know that you probably haven't studied this, and I know it's probably we're just opening it to you. I know that you've been studying for your exam. So let me tell you what I can about this as we go along. Now we're going to be talking about cognitive behaviors. We're going to be talking about problems with vision and hearing and speech. And then we're going to be going into those variations about adult and pediatrics. They're the same and they're different. They're not little adults, they're little people, and they are treated a little bit differently. You know, I'm one of those people, I did adults and I did pediatrics, so I understand the differences. And I think my adult nursing helped me in pediatrics. And I know if I go from pediatrics back to adult, it's going to help me in adults too. So I can actually tell you the differences. Not many nurses do both areas.
I had a quick question about that actually.
Yes.
So I'm really looking into, like further schooling in the future, and I really, I try to listen to CNAs. And I had mentioned that I was really liking my clinical time in the PICU and NICU, and they had all recommended to me that they weren't sure if that kind of experience in ICU would be the same as adult ICU as far as to get into like a doctorate program. Do you know if like adult health is preferred for like further education like that?
You can do, I did peds to a PhD. My
And it was fine.
dissertation is peds. It's only the second dissertation done in pediatrics at this university. You can do whatever you want.
Okay.
You can make it work. As long as it's a subject you expand upon and you prove it to be whatever it is. Whatever you want to do. I'm telling you, adults helps peds and peds help adults. Okay. So it's okay, whatever you want to do.
Awesome. Thank you.
No, you're very welcome. Let's get going. I know Mia wants to win this one. Go ahead. We'll try. We'll let you. Or Shanisi, watch out. Early detection of hearing impairment is critical. Which one is of primary importance? Now, if you can't hear, I mean, you're missing a lot of the world, right? But what is the biggest way that a hearing impairment affects you? And it's that ability to talk, right? If you can't hear, you can't pronunciate words. So getting hearing to the best it can be, hearing aids or cochlear implants needs to be done so that they can speak and, communicate better. I'll multi-select. A toddler goes to the ER complaining of fever, headache, rash that's itchy with a milky fluid. What do you think your nursing priority is here? What do you think this could possibly be? You know, whenever I see rashes, I'm always concerned, especially that fever and headache. It could be chickenpox. That's my concern. So get a mask on the child, on yourself, tell the doctor, vital signs aren't as important as that isolation. Keep them isolated for other. Get them in that reverse airflow room because the whole ER can come down with chickenpox. Even if you're vaccinated, you still can get chickenpox. Okay, so looking at the symptoms, that's like, okay, chickenpox, what do I do? I'll multi-select. A child's playing outside, runs into a piece of wood, gets a laceration on the forearm and needs stitches. What are we going to do? Now, children getting stitches, all they think of is needles, right? They're scared to death. Especially if you're 4 or 5 years old and they're bleeding and blood's going everywhere. Their insides are coming out. They're going to die. and it's not just a Band-Aid. So what we do is we prepare them with getting child life in there. Child life is amazing. They'll talk to them and distract them even while the laceration's being done, especially if they're held in mommy's or daddy's arms too, right? Also putting that numbing cream on so that it's numb, and don't let them see that stuff. Don't let them see the needles and the sutures. That's going to scare them, and you're not going to restrain them. The minimal restraints, the better. Having them held in the parent's arms with maybe a nurse there to assist, that is better with that distraction with numbing cream than anything we can do. I've had children have fingers sewn back on in mother's arms because they're held, they're comfortable, distraction. And then of course an iPad with their favorite show, whatever. A parent recognizes that her toddler has a speech delay compared to their older siblings. What is your nursing priority with this? Speech delay. So we know that the first thing we need to do is if a problem with speech, we need to check hearing. And then if the hearing is decreased, then we'll get into speech therapy. Okay, so number one, check the hearing first. I'll multi-select. What are an early sign indicator of impaired cognition? Signs of an early indicator of impaired cognition. You know, we need to know developmental stages, don't we? Because cognition has to do with all those developmental stages. You know, when you understand that a child's not talking at least 1 or 2 words by 1 year old, something's going on. And if they can't do that voluntary grasp, something's going on. And of course, they can't communicate. They don't know how to express themselves, behavior difficulties, because they're frustrated. I can't communicate. A child's being treated for a fever. The reason for treating the child's fever is what? Why do we treat a fever? And then I'll ask, do we have to treat a fever? And it's only for relief of discomfort. Once the child has a fever, the chances of seizures and whatnot are minimal. It is when they go from no fever to a fever in 20 minutes, that's the febrile seizures. But once they have a fever, they're actually safe. The reason why we give medication, antipyretics, how do you feel when you have a fever? Horrible. So do the children. And what do you need to do for a fever? You know, have plenty of fluids, right? Kids aren't going to eat or drink if they're feeling terrible. Get the fever down, they drink, they eat, run around, fever comes back, treat them again, and they continue, okay? So it's only for discomfort, really. A multi-select. A child's complaining something is in their eye causing tearing and pain. What do you do? Nursing action. You know, the book says if it's floating around, take a piece of tissue, get it out. Absolutely. If something is sticking in that eyeball, you are not going to touch it. Okay. Put a Fox shield on it. In fact, they say even both eyes, get them to an emergency room that takes care of pediatric ophthalmic emergencies, or go to an ophthalmologist that deals with children. And also check that eye for a reaction to light. Is that pupil still moving? Because if it's not moving, that's even more of an emergency. At that point, it's 911, get this kid to the ER now. Separation anxiety in a child hospitalized, which behavior indicates the stage of despair? Now, separation anxiety and hospitalization, there's 3 stages, okay? So you need to look, see what they are. The one of despair, what does that mean? So they get to the point where they're screaming and yelling and crying, and then they realize, that mom can't be here. So they sort of like say, all right, and they regress, which means they might be in the corner sucking their finger or getting their favorite doll or blankie and holding it because that gives them that comfort because mom or dad can't be here. So the stage of despair, they regress. And then they come over that, and then they become more active within the care as they go. They realize, okay, a child with a history of abuse, which therapy explores the emotional problems. I wish I never saw abuse in my career. I've seen so many different types, and it's sort of really sad. Some children I've seen devastating to me. So we go through play therapy, okay? And in play therapy, we can explore a lot of these problems. A lot of times we're going to do that with the therapist. We're going to do it with child life. Make it as non-threatening as possible. Sometimes we can figure out what's going on, okay? I'll multi-select. When can children react to the stress and anxiety of hospitalization? When? They know they're going to need their tonsils out. They need to go and get tubes put in their ears. They hear the doctors and the nurses talking and mommy. Anytime, before, during, after. And yes, they do stress. And if we think they don't, yeah, they do. And sometimes decreasing that stress and anxiety is showing them what's going to happen. Bring them to the hospital, let them see the machines, right? Let them touch the equipment, have child life showing them, what can go on so there's no surprises. Children do better when educated. A multi-select. An adolescent goes to the ER for treatment without the parents. How do you get consent for this treatment? This happens all the time. Parents are on vacation, grandparents, best friend has a kid, and the kid is a big fever, 3 days and coughing, and they're worried. They bring them to the ER. How can we take care of them? A client who's 18, who's confident, signs their own consent. You don't need parents. Sometimes if it's an emergency, they come in, they're, airlifted in, trauma, you don't need a consent. Emergency treatment can be treated 2 physician signatures until they are stabilized, then they need a parental consent. Also, you can call up on the phone and then 2 people will listen in that yes, mom agrees to treatment, okay? And then any child 18 years old with proof of age may sign consent. Are they cognitively aware or not? That is the big thing. Are they competent? Not all 18-year-olds are. How about a child with CP or autistic, etc.? A child is extremely fearful of hospitalizations. What type of play explores this? And that's called dramatic play. We talk about cooperative play. That's playing 2 kids together playing checkers, right? Solitary is alone. Diversional play is, when you like try to take their mind off of what's going on. Dramatic play is let them act out what's going on. What are they afraid of? When checking an IV in an infant, you notice the tissue around the IV is swollen. What's the first thing you do? Having 10 mLs of fluid going into an adult is not a big deal. What if it is a 1 kilogram kid? 2 pounds. That's a lot of fluid, and it will blow up a hand, a foot, head, whatever. First thing, turn it off. The second thing is, depending on what's been infusing, to, discontinue it, maybe put a nice warm pad on it, elevate it if you can, and then of course you're going to have to restart the IV if needed. In helping a child to adapt to a hospitalization experience, the best approach is what? Got to go to the hospital. They're going to be for a while. They're running a test. They're going to have this surgery. You know, you're there for 5 or 6 days. How are they going to adapt being there? What makes it easier for a child, especially toddlers and preschoolers, right? Routine, which means eating the same things as possible, nap time, bedtime, putting them in their own jammies, maybe dressing them for the day. You know, these are all things help a kid feel more control of their environment, and they're happier kids. When assessing vision on a child, the healthcare provider would use the Snellen chart. At what distance? You know, in children, remember, it's not going to be letters. It might be animals or shapes pointing up or down or sideways. They use different charts for children, but it doesn't matter. Adult kids, they're all 20 feet, okay? A multi-select. Nursing care of discharging a child to home. You know, your kid's going home. What do you need to do for the child and the family? What if they just had surgery? So we know discharge planning starts with admission, right? Absolutely. Providing instructions only to the parents. Well, what if the kid is 3, 4 years old? They understand. Please tell them what they need to do and they'll get it and they'll have better outcomes. You always give them that list of numbers in case of whatever happens and knowing when to call. And then when is it the outcome? When is a child supposed to feel better? What am I supposed to see? And always have that parent, you know, talk back the instructions, what they need to do for the child. That will get the kid home and the kid will be safe because you know you sent them home with proper instructions. What is a 3-year-old's biggest stressor of being hospitalized? You know, 3-year-old, this is your, you know, beginning of preschool. You know, they are better with stress, you know, than the toddler, but you know, what is their biggest stress? And that is mommy's not going to be there all the time. You know, parents have to go home, check on other children. Then you have to go to work. That separation from mommy and daddy is huge. So that is the biggest stress. And we always recommend, if possible, somebody staying with a child to keep them from being all stressed. It's hard sometimes, though. A multi-select. What is the best way to alleviate the stress and anxiety of a hospitalized child? I mean, number one is have parents stay there. We know that, but keeping them on the same schedule, routines and rituals, and then explaining those procedures on their level. Let them know what's going to happen. I love using Child Life. Child Life came into fruition in about 2008, 2009. And when they first showed up, I was like, who are these people in my room? And then I got to learn and understand what they did. Most of these Child Life people are bachelor, master, and doctorate prepared, and they are taught how to take care of children in a developmentally appropriate way. They're better than me at it. So let them do their magic because they do magic. A nurse notes a string tied around an infant's wrist. An appropriate intervention regarding that is what? I mean, like, why do they have that there? So just ask them. I mean, there's so many things that parents do to protect the child from evil spirits and things, right? So if this string is part of their cultural beliefs, leave it there. But If we need to get it removed because of we need that arm, that leg, or whatever it is, let the parents know about it, that you have to do it for better treatment for their child. But if at all possible, leave that there. The parents feel better, the kids feel better. How can a hearing impairment develop? It's all these things. It could be present at birth, could be some malformation of the ear. I mean, the whole ear may not be developed. It could be from an illness. I mean, how many ear infections do kids get? And if we don't treat them, quickly, that could cause it too. So all of those things can cause a hearing impairment. And then what do? We'll fix the problem. And of course, speech therapy. Which urine collection method on an infant is most accurate? So you have this little 4-month-old baby and multiple fevers, and mommy notices the urine stinks. And that's a very young age and very brittle. They don't have a big immune system, right? So we need an accurate testing of urine. And that's only by a straight calf. If we put a bag on, think about a girl, there's all this, debris within their labia. So are we getting urine or are we getting the debris, the superficial, contaminants? So we want to treat with one antibiotic. So do a catheterization. We get a great culture sensitivity, and then we know that the antibiotic they're on is the best. We don't want to put them on 2, 3, 4 different types of antibiotics. It could hurt the kidneys by then. A multi-select. What is the purpose and function of the family? Remember, family-centered care, right? We not only take care of the children, we take care of parents and siblings and grandmas and grandpas and best friends and aunts and uncles. I mean, it's the family. On some cultures, you get all of them. So that family provides that safe environment for growth and development. They provide that comfort, identity for their emotions, and that's where their values, attitude, and beliefs come from. So this is, the family that we need to take care of all of them, and that's many reasons why nurses don't get into pediatrics, because it's hard dealing with parents. And I was that nurse that you have a difficult parent. I always got it. They say, I hate to do this to you again, but you need to take care of this kid because that father is crazy, and we need to help you to help us keep him calm. And let me tell you, that guy came in with a gun one day. So one of the parents, yes. So I was the one who got those kids and those parents, and I dealt with them very well. The primary goal in caring for the child with cognitive impairment is to what? You have a child with CP, autistic, Fragile X. I mean, all of these cognitive delay syndromes. What's our goal? We want that kid to be the best they can be, provide optimum development. I was even just talking to my husband. Years ago, you have cognitively delayed children, Downs and autistic. Our goal was just to keep them clean and dry and fed and have them, taken care of clean. Today, speech therapy, occupational therapy, physical therapy, they're walking when they never could have before. Little Jonathan, where I was working in doing clinicals on ground, Jonathan was 7 years old, severely spastic CP kid. I mean, he would be tight and shaking, see me, and he would smile ear to ear and waiting for me to give him a big hug. That kid could, with a little pad, because he was nonverbal, could say, where's the oval shape? Push it. Where's color red? Push it. Years ago, that didn't happen. That didn't happen at all. So providing optimum development, giving them a voice, giving them a transportation, very important for these children. Many infants require oxygen. Which type is best tolerated and accurate? This is one of those questions from chapter 39. There's so many things. So oxygen, I mean, we think about that, the least amount you give is a nasal cannula, right? That's adults. In infants, especially the newborn, that clear plastic hood you saw on the picture, it's called an oxy hood. And you can measure that oxygen extremely accurately. And that kid can look around, suck his fingers, have a pacifier. Nothing's there touching him or taped on his face. And it's the easiest tolerated, and it is accurate amount of delivery of oxygen. What is best practice for school-age children with special needs? You have kids, I mean, special needs could be hearing or vision or even in a wheelchair. We'll get up to these myelomeningocele that are, mostly paralyzed from the waist down. What do we do for them? Put them in a special room? Today, I mean, when I was in school, there was a special classroom. Today, they're doing what they need to do. They're integrated into regular classrooms, and they're allowed to be all they can be. I mean, I've seen children myelomeningocele, which means they're not moving much of their low extremities. We'll get that into the neuro area, but their brains are perfect, and they would be able to have their brains work the way they should. And they're great children. They just can't walk. Doesn't mean they're not normal, quote. A multi-select. Collecting a heel stick blood specimen on an infant. Now, we don't have to stick a needle in the arm, the anticube, like we do for bigger people, adults and bigger kids. All we need is usually 1.2 mLs of blood. And that's a CBC, and that's some sort of blood level or electrolytes. 1.2 mLs, that's all you need. So warm it up, get it warm, the vessels dilate. You use the outer aspect because you don't want to hurt the middle of the heel because that can cause a lot of problems. We don't do that. And then make sure it's not too deep, because if you go too deep again, you're going to hit on the calcaneus and you could cause infections in the bone, but it works great. The other thing's a trick I'll tell you if you want to go into peds, hold that leg down below the heart and slowly, easily squeeze it and take your time, and you're not going to bruise the heel. The kid's not going to cry. He just thinks that you're just touching that leg. So those are the things you do for that. Referrals for cognitive impairment should occur when? So you see your kids delayed. They're not walking by 2 years old, or they're not, being able to roll over by 9 months old. That's part of being in that cognitive area too, whether fine motor, gross motor, those are delays. We do that as soon as we see it. That's why we do frequent developmental checks. That's why you go to the doctor, height and weight, see if the nutrition is good. We also go to the doctors and they look at what is your child able to do. And if they can't and it's too far out, guess what? Early intervention, speech therapy, occupational therapy, physical therapy, whatever they need. And as I've always said, kids are so resilient. A client with mild intellectual disability. I mean, many times you have a child with Downs, chromosome 21. And yes, they have Downs. And these children grow up to be adults, right? And when they grow up to be adults, they can live independently as long as they have somebody watching over them, because we know people will take advantage of them. I had one student tell me she had an uncle, he was age 54, living by himself in a home, but she was the person designated to watch over to make sure nobody took care of him. So that's where this child could be, living alone. Down's children have frequent upper respiratory infections. Why do you think? So they have this really flat, underdeveloped nasal bone. Mucus sits there and it, creates, all of this mucus and drips in the trachea and creates all these upper respiratory infections. The other stuff doesn't really create it. It's that nose. A multi-select. What would be included in the care plan of a patient with moderate cognitive impairment? And it's all the above, right? Structure and routine. When they are put it with these different sights and sounds and touch and good toys and things that we're doing is teaching them something. All of those things will help a child with cognitive development issues. Multi-select. Why do children with Down syndrome have frequent respiratory infections? Again, which one? You should all get it right this time. And it's that nasal bone. It's also, they breathe in their mouth, so they're not blowing their nose out and those stuffy noses. It's all part of it. The tongue has nothing to do with it. A multi-select. Autistic children demonstrate which behaviors? Autistic children, they say you really can't diagnose them till a minimum of age 2, about age 2 and 3. You can sort of tell earlier because usually they're cognitively delayed. And we know that as soon as we can get some interventions, these kids can do miracles. But these kids have problems. They can't speak. They don't like looking at you. They don't want to be touched. They don't like lights. They don't like loud noises. They play by themselves and they're not going to answer you. They're in their own little world playing in the corner. You have to go up and really say, hello, Christopher, are you listening? And then they do listen. I've seen miracles with having that, having all those therapies, speech, physical, and occupational therapy. I've seen autistic kids actually be part of a group, come into the school in the morning and know that he had to put his book bag down and sit and get vital signs before he could play. An autistic child to do that, that was amazing. Oh, and he was Downs too. A multi-select. Children with autism have better outcomes if they need a structured routine. They know how to communicate. They need to know how they can, because a lot of them don't know the words. So some effective way of communicating, and you're not going to allow bad behaviors. You need to correct them as they happen, and have them understand why. And licensed therapists only, mom and dad, brother, sister, all of them can be part of doing the therapies too. So it's the combination of both. A multi-select. Fragile X. Second most common cognitive delay after Down syndrome. They're extremely similar, but these children usually are extremely aggressive. So these children usually need medication also. But they do have the intellectual disability and learning difficulties, and they have big ears, big jaw, different things that are going on, but they can eat what they want. It's not like that's part of it. They are like Downs. After Downs are the second most common, but they have more of that behavioral issues, which do require medications on these children. Causes of autism. Isn't it the varicella vaccine, the chickenpox vaccine, like that one physician said on that false study that drove everybody crazy and still does for years? We don't know. We really don't. Genetics, abnormalities, unknown. We just don't know. If we did, it would be good. Autism strikes boys more than girls. Ways children with hearing impairments communicate with others. Sign language, lip reading, finger spelling, anything. Hey, you punching on you, going, I want to eat, right? They can tell you what they want. Amblyopia. What is that? Has something to do with the eye. Excuse me. It's called a lazy eye. So one eye sort of goes the wrong way. It doesn't go straight, doesn't match the other. And there's a muscle weak in the eye, basically. So what you do is you patch the good eye and make that bad eye work. And you take it off and on every 2 hours during the day. And you make it work. And that usually corrects it. Just a lazy eye. How would you help encourage a preschooler to be less apprehensive when taking their vital signs? You know this one. And of course, let them touch the stuff on their level, have fun with them, and then say, here, let me take your blood pressure, do mine first. What number do you like? La, 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 la. And let me tell you, these kids will help you and enjoy getting their vital signs done. What child may be more stressed when hospitalized? Believe it or not, it's that kid who's in the hospital repeatedly because they probably have had a bad experience and they remember that. So as nurses, we try to make every child's experience the best we can, especially like a sickle cell kid, in and out all the time, right? Sticking them with IVs. So the one who's frequently hospitalized has more issues and are more stressed. A toddler has a hard time fixating on a single point, and the child's eyes cross the midpoint. What's that called? They don't know how to focus. It's called strabismus. It's like the eyes, you'll see them wiggling, okay? Because they're trying to get there, but they can't. Again, it's a muscle thing. We need to, help those muscles get stronger. I'll multi-select. Safety and administering medications to children include what? We know with medications in children, it's different than adults. It is milligrams or micrograms per kilogram, and it really needs to be calculated by the physician and by yourself to make sure. That's number one. That I'll tell you for sure. Always check the name band and don't ever ask the child, because children have different names. Parents call them different things. So don't do that. And you never check a room number. It's always the name band that we checked to be sure. They're doing lots of studies in the hospitals today, making sure that those kids have name bands on. They'll go around the emergency room, making sure every kid has a name band on. They're doing these studies. And if not, they're saying, hey, you didn't get the name bands on your kids. What can help the parents to make a baby swallow their medicine? Babies, you put it in and they spit it out, right? How are you going to get it in there? Some kids just don't like it. What you do is you put it in your mouth, you take a deep breath, you tell the parents, and real quick. And the kid's shocked and he swallows it. And it works really, really well. Either that or you hold them down and pinch their cheeks, and that's miserable, but really works. Treatment for amblyopia involves, I told you, what did I say? So amblyopia is a lazy eye. So you cover the good eye and let that lazy eye work so that muscle gets better. The nurse is discussing sexuality with the parents of an adolescent with cognitive impairment. What's important? I mean, you have a teenage girl who has Down syndrome. What do you need to let them know? They need to know what's good touch, bad touch, right? A well-defined concrete code of sexual conduct, because they're not nice people in this world that will take advantage of these little girls, even little boys. So if they know what to do, they're going to be safer. And a multi-select. A child is asking mom about his sibling in the hospital. How can you alleviate the sibling stress and fear? His brother's in the hospital, you know, and he was just brought in an ambulance and trauma or had surgery, and he's worried. Very, very commonplace occurrence, this is. So let him make a card, send it to him, or let him, if possible, go in for a visit, but prepare him for what he's going to see. It is the best thing to do for that child because they're worried. And last question, what types of play allows children to express their fears of hospitalization? You know this one. And that is your dramatic play. Good job, guys. Thanks for being patient tonight. No, I ran a couple minutes over. Number 3, Ashley. Good job. Number 2, Amber. Whoop, whoop, whoop. Number 1, Mia. Number 4, Heather and Angela. Good job, guys. Sign your attendance attestations. As I said, you all did really well on your exam, so please take a deep breath. Don't beat yourselves over the head. And I will get those grades up by Saturday, early afternoon. Any questions, please let me know.
Ma'am, question.
Sure.
So with the lazy eye, do they have to be kids like to correct it, or can it be corrected while that person?
Even adults. Absolutely, in adults you can. So you guys have a good evening. Thank you so much for the patience with you.
Professor, Dr. Bogert,
Yes.
I have